You are now listening to the Ultrasound Podcast with your hosts, Matt Dawson and Mike Mallon.
On the last podcast, you may have been a little overwhelmed by the number of intelligent comments that Matt and I made during the Lung Journal Club with guest stars Harvard Medical School and Christian Larson, lead author of the Lancet article. Or maybe you noticed that we didn't really have anything to say at all. Well, what do you expect? Look at the group we were competing with. Vicky Noble, Andrew Lateplo, the ghost of Mike Stone. It's amazing we were even able to breathe in a room that's strapped for air. Luckily, we get to edit the podcast. So in this second edition of the Lung Podcast, we've managed to go back and dub in our own voices when Andrew and Vicky ask smart questions. So watch out, Harvard. We found a way around your smarts. Seriously, it's amazing the amount of attention this article has gotten in the blogosphere. Matt brought up a thought-provoking point at the end of the last podcast about the true diagnostic utility of many of the tests that we order. He mentioned the lack of mortality benefit of a CBC or a chest x-ray or a BMP. While we are listening to the second half of the podcast, I want you to contemplate on how each one of these diagnostic tests, especially ultrasound, do not occur in a vacuum. We take in a multitude of data points with every patient presentation to come to a diagnosis. Is it even fair to try and measure an isolated diagnostic test such as ultrasound, which is really more of an extension of your own senses? Honestly, I'm impressed that ultrasound can perform so favorably when held to such high standards. In the last podcast, Vicky eloquently described Christian's study, and Christian went into detail regarding the protocol and why he felt there was no mortality benefit and an increase in testing during the early portion of the patient's stay in the hospital. Now let's get into some more abstract concepts like the generalizability of the study and analyze that increase in testing a little bit more.
And I think that brings up an interesting point, Vicky, that I've actually got a question for Christian about. Great job, Christian, by the way. This is a really interesting study. Actually, I have two questions. So the first question is, I think the most important aspect of the study is actually you. So I'm really interested in how well trained you are in ultrasound, so I know how much I need to train my residents and students and fellows so that they can go and perform ultrasound this well and make this much of a difference. And then the second question is kind of speaking to what Vicky was talking about, this whole idea that we're increasing the amount of testing because of the ultrasound. I think one strong argument is that it's just happening earlier. But then if you look at the actual number of tests that people get in the hospital, there actually were a few more tests in the ultrasound group than in the non-ultrasound group, although not significant, just a trend towards more in the ultrasound group. Yeah. How much of that do you think was because either your physicians that were taking care of the patients or the consultants that you were admitting these patients to were uncomfortable with the diagnosis made by ultrasound? So how much of that was because you weren't basically performing this study in a bubble where because you make the diagnosis, bam, that's the diagnosis, when in reality we all know if I call a surgeon and tell them that somebody has an appendicitis, 50% of the time they're still getting a CT scan because somebody doesn't believe me.
Yeah. First of all, the question about how well trained I am, as some of you might know, sonography in Denmark definitely is not as far in the ED as it is in the States. So in order to be able to train in sonography, one has to go around at the diversity of departments in order to be better to do that. In the cardiology thing, I have attended some of Professor Slot's courses there. And then I've tried to hook up with some of the cardiologists and met them to give me some feedback on how to do it correctly. So I took this one-day course, and then as a part of my residential training, I've also attended the cardiologist department and get them to look over my shoulder. So I think I have approximately 50 supervised echoes, and afterwards I then just continue doing focused echoes. And at the point in which I did the study, I think it was around a little bit above 200 focused echoes. Concerning the lung part, then I'm a senior resident in pulmonary medicine. So lung is what I do every day, so to speak, and it isn't that widely used in Denmark, and there's no formal training. So I have just scanned loads of patients. I think at the moment when I began the study, I have performed above 400 point of care sonographies of the lung. Some of the diagnoses which are used for the lungs are mostly point of care testing with pneumothorax, interstitial syndrome, and so on. And I think there are several studies which have documented that you don't need that much training to be able to exclude or diagnose these conditions. And lastly, the limited compressional ultrasonography, I had performed, I think it was above 200 when I performed the study. So my training program is not very regular, so to speak. Fortunately, since I began doing the study, it has been well standardized in Denmark with guidelines and so on, which we try to set up to a defined number of scans and also be evidence-based. But I was just unfortunate to be the generation prior to that, in which there were no formal training.
Did you feel like there was a change between when you started your study and towards the end, and the confidence that the other physicians had in your ultrasound diagnoses and the consultants had in your ultrasound diagnoses?
Yeah, definitely. As I said, we made a pilot study prior to the RCT, and some of the physicians who were at the department at that time, which were also in the department when the RCT took place, had more confidence because they knew from the prior study that when you perform focused echo, then when the cardiologist came into the department, he would confirm the diagnosis. So they were more confident. But of course, some of them, maybe the younger residents who had no knowledge of sonography, were maybe a bit more skeptical to the findings, and so to speak, and had perhaps a more conservative approach. You asked about the additional diagnostic tests, whether they were as a result of the sonography, whether they were performed because they didn't believe the diagnosis, and so on. I think most of definitely what was intended in the study was if sonography showed a diagnosis such as heart failure, then we wanted the cardiologist also to assess this patient and confirm the diagnosis, rather than simply the diagnosis being done in the ED. The same with pulmonary embolism. If it was suspected, then a subsequent VEQ scan were ordered. But what's also, in my opinion, is a bit interesting, if you look at these additional diagnostics being ordered and then compare what was suspected, what was the suspected diagnosis for them being ordered, actually more patients in the POCUS group had a correct presumptive diagnosis made, which leading to the sonography. For instance, if left-sided heart failure was suspected, that was also often what was confirmed as the initial or final diagnosis, whereas many patients in the control group in which heart failure were suspected, then when an echo were performed by cardiologists, then the diagnosis could not be made.
Hold on right there. Christian's making an important point. Not only are patients getting the right diagnosis earlier with the ultrasound group, they're also having more appropriate testing performed. By that I mean additional diagnostic tests are more often positive when preceded by bedside ultrasound. And you can imagine how this happens, right? Patient has a clinical presentation concerning for PE, ultrasound shows a DVT in the left leg, CTPA is performed and shows a big clot in the lung. Your pretest probability for that CTA was dramatically increased by the positive lower extremity duplex study. In fact, maybe you didn't even need that CTPA. And this is how medicine works, right? Everything we learn about the patient, whether it's the H&P or a bedside ultrasound, affects your pretest probability for disease. Now, I know that's not an outcome difference, but if our job in medicine isn't to diagnose disease, then aren't we all just palliative care physicians? Eventually, maybe bedside ultrasound will be well accepted enough not to require confirmatory testing. And in many modalities and some healthcare systems, I believe it already is. But in the meantime, at least using it to direct you to more likely diagnosis seems to make a lot of sense.
Dr. Larson, I have another question. I'm Nick from Canada, which is basically the equivalent of Tim from Plattsburgh. I don't even know what a gadfly is, so...
The Ultrasound Podcast does not condone any derogatory comments towards Nick from Canada or for Canadians in general.
I'll just keep it simple. Did you, while you were doing this, take note of how long it would take you to do all three systems?
Yeah, I did. I can't remember the exact median time, but I think it was around 12 minutes. All these things take time. And of course, if you need to shorten the time that you use, one fast thing was not to do the DVT assessment in all patients, simply because it takes time to get, if the patients had something on their legs, you have to remove it and so on. So it's more easy to do the lung and the heart examination in one assessment. And the other thing is, in order, as a part of the study, I also had to to save all images of all projections and so on, and as a part of documentation. And of course, if you don't need to do documentations, then the time span needed would probably also be shorter. But of course, this doesn't come for free, and it takes time, so to speak. But I think most of you probably also do this as if I go and examine a patient, then I perform sonography as an integrated part of both history taking and clinical examination. So I scan the patient and I talk with the patient simultaneously, so it does not necessarily take extra time. So I don't just talk with the patient and afterwards scan, so that can be saved some time there just by integrating it into the other things you do with the patient.
Vicky, might I pose a question?
Of course. Dr. Doty, please do.
So, Kristen, thank you for taking time to talk to us about the paper. One of the critiques of the study is that you were not really able to show a difference in patient-centered outcomes. Let me ask about sort of hospital-centered outcomes. Did you look at costs? Was it more expensive having done all these tests, or the few additional tests that were done on the intervention group? Were the costs different?
No, we did look at costs because we would have some trouble about how to evaluate the cost. But roughly speaking, as you see, there's no difference in length of hospital stay, and there's at the entire stint there's roughly no difference in the number of initial diagnostics being ordered. So roughly, I would say there's no difference, and the problem is also how to assess what the sonography cost, as simply because I was there as an extra, only doing all the sonography and only getting paid from the university. I don't know how to add that to the costs. Maybe you should all just hire a PhD student to do it in all patients. That would be quite key.
Do you need a job next year? And maybe
yeah.
So I'd ask a follow-up to that. This is Roger Humphreys at University of Kentucky.
Quick note, this is the chair of my department, and it was the vice chair of my department that asked the prior question. I'm very lucky to have such sono-interested bosses, and as you can see by looking at them, I was hired specifically to drastically increase the amount of hair in our department.
So what about, did you look at the percent of positive tests that were ordered in each group? Is it possible that the point-of-care ultrasound had 75% positive studies, whereas the studies that were ordered outside of the POCUS group had a lower percentage of positives? Because that's what we want. We want to basically only order tests that confirm and finalize the diagnosis.
We looked at it for those ordered in the ED, the number or the proportion of diagnostics in which the diagnostics confirmed the diagnosis was 47% roughly in the POCUS group, whereas it was only 26.9 in the control group. And if you look at the entire hospital stay, it stays around 48% in the POCUS group and 39.2% in the control group. So definitely, in my opinion, that the additional advanced diagnostics being ordered are being used more rationally rather than just not confirming a diagnosis, as in most patients, or in 2/3 of the patients in the control group, the advanced diagnostics did not confirm the diagnosis that for which the patients were actually referred for the diagnostics.
Dr. Larson, I did solicit some questions from Twitter as well in the last couple of days. Really, we've discussed and covered pretty much everything. There was one or two other questions that I was hoping to ask you, if that's okay with you.
Yeah, no problem.
I'm just going to read them straight from my email. The first one is, let me find it here. Hi, Matt. First off, you're my hero and clearly the more talented half of the podcast. Oh, sorry, wrong email. Hold on. Let me find it. That's the wrong one. Here we go. All right. Yeah, this is from Rory Spiegel. He's at EM Nerd on Twitter, and he blogs, and you probably read some of what he said about this study, some of his comments. We basically already addressed all the main issues he had with the study, the questions about the mortality and overdiagnosis. Should we be moving away from purely diagnostic studies comparing ultrasound to an impossible gold standard that's not typically used to guide decision making? Rather, should we focus on studies examining how patients with diagnoses made by bedside ultrasound benefit from a specific treatment? The example he gives is patient with a negative chest x-ray and positive ultrasound for pneumonia. Should we try to randomize those to antibiotics or placebo and figure out how to treat these patients who have a negative x-ray and positive ultrasound, look at these more subtle diagnoses that ultrasound are making and see whether we can treat those or not? And then the follow-up question to that is In your view, how does this change ultrasound education?
I think the first question definitely about the outcome and what does this actually mean is of course an important question. But secondly, I would also say that it would be a rather tough study, because you can say if you had test X-ray a negative pneumonia and then sonography only finds a small pneumonia consolidation, most of these patients would probably do pretty well no matter what. So it would be pretty tough time to show there's any hard outcome difference in these patients. So I think that would be tough. Maybe if you look at some of the more critically ill patients would have a negative supine chest X-ray in which you find a large pneumonia in these patients, I think in those you would maybe find a difference, but not in the everyday ED patient coming in with some fever and some expectoration. I don't think you'd be able to find a huge difference in those patients.
You know, I just realized something. When we talk about ultrasound being possibly more sensitive than X-ray for pneumonia and rib fractures, some people probably think we're making the point that it's horrible that X-ray is missing these, that we think patients are being harmed by these misses. Personally, though, that's not the point I'm trying to make when I talk about this. I think it's probably pretty rare a pneumonia or fracture is significant if X-ray doesn't pick it up and they're well enough to go home anyway. I think it's pretty ridiculous, though, that we walk away from the patient, push a button, have someone else bring in a big X-ray machine, send that film to yet another person to read, and then we read that report, when instead we could pull a device out of our pocket immediately while talking with them and get the answer at least as reliably. It's more of an efficiency thing, even if you ignore the radiation mitigation benefits. And the graphic that we showed you earlier really drives home that point.
Hold on, Matt. I know you're in the middle of a point here, but I gotta bring something up. Lung ultrasound has been shown to be highly accurate in specific settings looking at specific diagnoses, such as pneumonia, pneumothorax, interstitial syndrome, the list goes on and on. But most of these studies have been in the hands of ultrasound super users. Now, I'm not saying using ultrasound as our gold standard for the diagnosis of these diseases is not something we should strive towards. But I am saying that unless you have a significant amount of experience in lung ultrasound, your outcomes might not be as convincing as Dr. Larson's or someone else who's so good that they wrote a paper about it. Just keep that in mind. All the more reason to practice, practice, practice.
So one other question that he had that we've kind of already addressed, but I just want to put a very fine point on it. That increased signal, that trend that we probably shouldn't even talk about because it's a trend of the increased mortality in the ultrasound group, in the POCUS group. I mean, it seems like that's probably pure noise. You kind of talked about it a little bit, and that there are really hardly any unexpected deaths. Is there any other explanation? What is your best explanation for that? Is it just pure noise, or is there a real explanation for why that number is a little higher?
I tried, as you probably also were, I was also surprised by these findings, and of course it's not nice that when you expect maybe to find a small trend, or what we should call it, towards the sonography group, it's not nice to see the other thing. What I tried to do was to take every patient who had died and just go through the journal and to find out what had happened to these patients. And that list is actually included in the appendix of the paper, so you can also see each of the patients. And I weren't able to find any single thing where I could say this was due to POCUS being performed, or this was due to POCUS not being performed. So as some of the patients, we had a patient with certain cardiac arrest, which had been diagnosed with pulmonary embolism and had been correctly treated. And maybe if this patient had been in the control group, the same would happen. And we had a patient with severe vasculitis being admitted in the sonography group, in which the vasculitis was not correctly diagnosed in the ED. But then again, I wouldn't expect vasculitis as being correctly diagnosed within a few hours in the ED, and I wouldn't consider sonography to significantly contribute to that diagnosis. So I don't think if I go through the list of deaths in this study, I'm able to see neither that the sonography had prevented any deaths or that sonography was the cause of any deaths.
If you have any doubts, or you're one of the people who have suggested that maybe the ultrasound actually did lead to overtesting and that the mortality difference trend was possibly real, then take a look at this. When you actually look at all of these, it's pretty clear. I looked through myself and was convinced.
So, but if you want to go, you can see the list in the appendix, so feel free to look through it and see if you can find anything there. I wasn't able to.
No, I did. I saw that appendix and I looked in it, and there's clearly no, for example, a small pleural effusion that wasn't on X-ray that got thoracentesis that led to iatrogenic cause. Yeah. There's clearly nothing like that, correct? I saw nothing.
I felt like there was a slightly disproportionate number of patients with asthma, something that we would probably consider to have a low mortality in the control group as opposed to the ultrasound group. And then there were a few more of the disease processes that I would think have a higher mortality that were higher in the ultrasound group than in the non-ultrasound group. So I guess, you know, from my perspective, my take on it would be that it probably is more noise. And just that the not quite powered enough to equalize those two groups.
No, and of course these patients, since the inclusion criteria are relatively wide in order to make an everyday patient, of course these patients are relatively different in which diagnosis they have and what their prognosis is. So if we instead had taken some relatively well-defined patients, then the prognosis in the groups would probably have been more similar as well.
I have a quick question. It looks like in the ultrasound group, significantly more patients received IV fluids.
Yeah.
You think that what were the ultrasound findings that might have pushed one to give IV fluids?
As a part of the focused echo protocol, it also includes assessment of the inferior vena cava. And a proportion of the patients also had a small collapsing inferior vena cava, and of course the physicians were informed of this as a sign of hypovolemia, and those they were given fluids. And as well, as you can see, also the diagnostic accuracy for pneumonia are higher in sonography group, and as probably you also have, if there's suspected infection and so on, fluids is a part of the treatment regime. So I think it was a combination of hypovolemia being detected in the sonography group, as well as patients being diagnosed more early with pneumonia, and then as a part of antibiotics, also fluids being ordered for those patients.
That's interesting. Christian, I have probably the most important question of the entire hangout. What was more important, the cardiac ultrasound or the lung ultrasound?
Careful.
Yeah. That's a very good question. I'm quite sure that.
Just say CBT. Switzerland.
Yeah. If I don't answer fate, then Eric is probably going to kill me. But of course, I have to say that lung.
I would have to say that cardiac sonography was the most important.
Definitely in my opinion, because of course you can't see pericardial effusion in if you do lung, but you still be able to see if there's any significant heart failure if you do lung and see there's plenty of B lines. So in my opinion, I would do lung if I only could.
Andrew and Vicky, did either of you all have anything extra to add about just kind of where ultrasound education should go in the future, instead of just the focus on diagnostics, how we take this to the next level of what to do with these subtle findings that we're all of a sudden able to diagnose that we couldn't before?
It's a really hard question, because these subtle findings, I mean, as you know, sometimes you look and you see a small pleural effusion with a negative x-ray. What do we do with that? Should that person get a CT, or do we just note it and tell them and do nothing? As far as the education goes, I don't know. I think the hardest part is really how to incorporate all those findings into your clinical practice, and that's just really the best way to do it is just with real patients as you're making real-time decisions, right? That's stuff that just scanning lungs is not really going to teach you.
I think the other thing is, I think as we've become more sophisticated in our education techniques, we have more cases, we have more, sort of algorithms of you find this, the patient has these vital signs, you do this. And so we can be smarter in sort of our education tools. I think we used to just kind of focus on here's a picture, what do you see? But now we should focus more on here's a picture, what do you do? And that just takes time for us to develop those techniques.
Do you guys think that we're ready to transition our studies towards sort of more patient-centered outcomes, or are we still trying to figure out whether everybody can do this ultrasound thing or not? Have we adequately answered that question, specifically, I guess, for lung?
I think we're in a middle stage. Jason had a good point about the outcomes might not necessarily be influenced. I think you need a really large study to show that patients are doing better. I still think there's a lot of gray area in how to interpret your images. For example, if I see some B lines on the right side and maybe a little bit on the left, what am I calling that? Am I calling that pneumonia because it's more focal? Or am I calling that CHF pulmonary edema because it's bilateral? And as we know, there's a lot of subjectivity to interpretation of B lines. So I think there still needs to be a little bit more data and research.
Outcomes are going to be tricky because it depends, right, on what we count as a bad outcome. I think ultrasound always wins in terms of making things happen faster and making the doctor feel better. Like I always feel better if I see this and then I can move on to other patients, or I can just, my brain can go other places. But I think it's going to be really tricky. Patient-centered outcomes are a hard thing to prove, especially when the morbidity and mortality for things like small pneumonias, renal colic, biliary disease, even small pneumothoraces, these things are probably not killing people. And so it's going to be a hard thing to prove.
So, Mike, just to address something that you said a minute ago, as an ultrasound outsider, I think that a lot of this research needs to focus again on Tim from Plattsburgh, to use the Harvard vernacular.
Tim no longer works in Plattsburgh, so there's no HIPAA anything. He's like anonymous, but yeah.
Well, I mean, just look who's talking about this, right? We have 4 academic medical centers and some of the elite point of care ultrasonographers, in lung and cardiac, and then also Matt. That are discussing this, and I think that part of the problem is that's not really translating to most of where the money is going to be, and the vast majority of ultrasound users in the country. So I think a lot of the research needs to focus on the common person doing it, and not Mike Mallon or Vicky Noble or Andrew Lateplo.
Yeah, if I could show that Doty could learn this, then that would be the end all. Like, we're done.
You could train a mentally retarded chimpanzee to do it if you can train me to do it.
I think we're going to start saying Doty from Lexington instead of. Although he's really from Brooklyn, right? Exactly.
All right, here's that diagram we keep mentioning. If you really look at it, internalize it, and think of the implications, it'll blow your mind. Look at this and think about how many of your respiratory distress patients get an x-ray ordered and how many you ultrasound. And then consider if that makes sense when we know from this that the x-ray will make the diagnosis 1.6% of the time over and above clinical exam and ultrasound, while ultrasound will make the diagnosis 14.8% of the time over and above clinical exam and x-ray. So you choose which one you want if you can only have one for the patient in front of you with shortness of breath.
This is a figure taken from the publication of our pilot study, in which we did blinded sonography of basically the same type of patients with respiratory symptoms. And then as a part of the results, then we compared the patients with all the diagnoses made in the group, and to what extent the physician performing the primary evaluation were able to diagnose these conditions. And the same with chest x-ray and as well as sonography. And as you can see, the physician, just by examining the patient, taking history, were able to diagnose a large proportion of the patient's diagnosis, namely 60%, whereas chest x-ray were able to diagnose less conditions and sonography more conditions. And in my opinion, what's interesting here is the overlap between these circles. As you can see, actually, if you were to do chest x-ray, of these diagnoses, chest x-ray would only contribute with 1.6 of the diagnosis, whereas sonography could add nearly 50% of the diagnosis. So if
Christian, I have to tell you, we talk a lot about visual representations of our data, so you have to make that chest x-ray circle way smaller.
So if you don't know what Vicky's talking about, it's because we took some liberties and actually edited the diagram with Christian's permission. The numbers are the same, but these circles are now drawn to more accurately represent the numbers.
I know. But the problem is that the numbers can't fit in then. They're too small.
Just have an asterisk or something.
Yeah, maybe.
All right, well, thank you guys so much. Christian, thank you so much for, you did a very good job.
It's going to be tough to summarize an hour of intelligent comments made by smarter people than us. So if you want to hear something again, hit that rewind button. They'll do a better job than I can. Basically, in the last hour, we talked about a new randomized controlled trial on the use of ultrasound to direct a provider's diagnosis in a European emergency department. We found that ultrasound dramatically improved the rate at which the correct diagnosis was made, allowed for earlier and more accurate additional testing, but did not offer a mortality benefit. Although comments have been made regarding the increase in testing in the ultrasound group, we found that the testing was just occurring earlier in the ED rather than on the floor. There were also negative comments about the trend towards increased mortality in the ultrasound group. Here at the Ultrasound Podcast, we try not to acknowledge trends in scientific data, since they are not statistically significant. However, close analysis of the deaths elicit no clear events where ultrasound led to a patient's death. Finally, it's worth saying that we are at a point in ultrasound research where we need broad, generalizable data, where the scans are performed by all the physicians in a practice setting, and the outcomes are not only isolated to diagnostic accuracy, but include clinical questions and explore the idea of incorporating ultrasound into decision rules and the overall patient presentation and outcome. Finally, thanks to Christian for sharing his groundbreaking research with us, and to Harvard for making us look smarter than we deserve.
A little bit better place than we had earlier.
I can lift you up. I can show you what you want to see and take you where you want to be.
If you're not good enough at ultrasound, that's not an excuse to punish your patients with radiation.
Get out there, ultrasound some hearts, some lungs, some IVCs. Let us know how you feel about it.